Thank you very much, and I'm most grateful for the opportunity to be with you this morning and to revisit something that we did in 2008 by bringing together a consortium, a group of people to look at what was the evidence around nutrition interventions and what difference they could make, largely from a survival context. Now, I want to acknowledge a number of people who have helped us put all of this together, and I particularly want to acknowledge the young people. So the one difference from the 2008 exercises that we were able to engage across various geographies and institutions, the future leaders in nutrition, and that particularly pleases me because this is a field that will require revisiting. We used the framework that Bob has already pointed out to you of looking at a conceptual organization of nutrition interventions, and the specific piece in here are those that directly address nutrition. Now, Bob has said that the evidence around much of this is strong. Yes, for certain areas, but for many other areas, we have also highlighted in this paper where we wish the evidence was stronger, particularly around adolescent nutrition and nutrition in the preconception period that contributes to birth outcomes, health of the mother during pregnancy and beyond. We believe that the evidence base around some of those interventions, although promising, could be much stronger. And I very strongly endorse what has just been said by Sally, that the boundaries around the first 1,000 days are a very good unifying framework, but they are scientifically not cast in stone. Much of what can be done for improved nutrition and health outcomes starts much earlier than the proximal part of the 1,000 days, and things don't just finish at 24 months, and there's a lot of scope for gains beyond it. So what we did in this exercise is to start from where we had finished in 2008 by looking at the nutrition interventions that were reviewed at that time. We looked at also the evidence of what had already been implemented, and what evidence had come forward since that time, particularly around effectiveness interventions. Unlike what one of the commentators has said in this series, we did not restrict our review to randomized controlled trials. We looked at quasi-experimental designs, alternative methods, and looked at a lot of the evidence that came out of the Campbell network as opposed to the Cochrane network. So we did throw the net out wide. What we did not include are quotes unquotes fuzzy-wuzzy expert opinions. So a lot of what we have in this paper is based on pretty sound review of the literature. So we updated and enhanced what we have on the evidence base, and I encourage you to go through the paper and a lot of the background documents, plus several papers which are in publication, which detail specific interventions. And we looked at things across the life cycle. So if you take the life cycle or course, starting from, as I said, the pre-pregnancy period, women of reproductive age, pregnancy, newborn period, infants and children, and beyond, because of our focus largely on children under 5, sadly, I wasn't given permission to go beyond 5 years of age. But in another life, we will. So the conceptual framework that you see here looks at all the interventions that we evaluated in depth. The ones that are shown in bold are the ones that finally found their way into a model based on the strength of the evidence and what could be fitted in within the LifeSave tool model that I'll speak about in a minute. The new thing in this series compared to what we did a few years ago is the delivery platforms. We particularly looked at not just the biomedical interventions, but on what needed to make them available to people at need. So implementation platforms, delivery strategies, things that removed some of the barriers to access. So if you look at the specific interventions, they're all enlisted here, and they've all been evaluated with specific impact estimates, and also the confidence intervals around some of those estimates in the paper themselves. We have looked at things, particularly across age groups, and I want to point out that for the newborn period, there is a huge need for better definition of what might be interventions that link nutrition or nutritional relevant interventions to survival. Now, we have not been able to do justice to that in this particular series for lack of evidence, but at least the first step has been made. And hopefully by next year, when unfortunately we'll do a newborn survival series again. We will have an opportunity to do some of this in better detail. But we've looked at interventions for infants and children, particularly around breastfeeding, complementary feeding, micronutrient interventions in great depth, looking at the risk-benefit ratios and also evidence for impact on nutrition, as well as developmental outcomes when they were available. Now, we mention, but do not elaborate in great detail on the disease prevention interventions, particularly water sanitation and hygiene. And since some of you may ask this, let me clarify. The reason for not doing so in this series is because we've just done it. So as Richard pointed out, we've just had the diarrhea and pneumonia series released a couple of months ago, and there is quite an in-depth discussion of environmental, health, hygiene, water sanitation interventions within that, as well as an estimation of their potential benefits on life saved and outcomes using the same tool. So therefore, there was little need to duplicate this. And those of you who would like to see some of those numbers quantified and impact estimates, you just have to pick up that series to get that figure. The delivery platforms that I mentioned have been reviewed in this particular paper as best as we could. And the details are in the web appendices and companion papers. And I will spend a little more time on looking at the community delivery platforms in particular, because they allow us a useful strategy to reach those who are not being reached at the moment, particularly in rural populations. They may not be appropriate to the urban poor yet, but they have a considerable amount of promise in terms of getting us there. Reduction of financial barriers, cash transfers, conditional, unconditional microcredit programs have been evaluated as part of this exercise and also detailed in Mary's paper that she will talk about. We also look at fortification strategies, again, from the lens of the promise for the future. Unfortunately, as you will see, a lot of the outcomes that have been evaluated from fortification programs have neither been at scale enough to look at mortality or morbidity outcomes, but have looked at surrogate markers that allow us the basis for assessing their contribution to public health in real tangible terms. So we have put in a full panel on fortification strategies and provided the evidence that we have at the moment, and also highlighted the evidence that we do not have. But those platforms are there. We also talk about school-based delivery platforms, recognizing that this series is focusing on children under 5, but they've been highlighted as opportunities for the future, particularly for adolescent girls as we go forward, and for maybe the integration of nutrition and child development interventions going beyond this period. So I want to give you a few examples, and I'm only going to give you 3 of the type of evidence synthesis and outcomes that have been synthesized in this paper. So if you take breastfeeding, we do not look at the biological benefits of breastfeeding only. We look at strategies to increase the uptake and coverage of exclusive breastfeeding. So the evidence provides data on impacts at various time points, exclusive breastfeeding, day 1, 4 to 6 weeks at 6 months, and talks about the evidence that's now available from community outreach programs on what can be improved and gained. And it's quite promising. And not just promising in the right direction of improving coverage and practices, but also reducing negative practices and effects that we have on reduction of people who are not breastfeeding at different time points. So we look at both ranges, and as you can see, community promotion and health worker platforms do have an extremely valuable impact on increasing exclusive breastfeeding rates and reducing breastfeeding failure rates. On complementary feeding, we expanded the exercise that we had done in 2008, 7-8, to look at the impact of educational strategies in populations that are food secure, and this is an extensive review that has taken us a long time to do. The data are presented as outcomes available around height gain, weight for age z-scores as standard mean differences. We've also looked at food insecure populations, or what can be done with just community education and promotion, and what are the additional gains of adding in a complementary food provision strategy. So we have provided the basis for looking at decision making in varying contexts in terms of food availability, insecurity, or food security in those populations. And this has, as detailed in the paper in the web appendix, been also translated into impacts on outcomes like stunting at various ages. We've looked at micronutrient interventions in detail, and for those of you interested, you will find your favorite interventions in there: vitamin A supplementation, including all the recent evidence of effect which may not necessarily be in the right direction. So those summary data are there. We've looked at preventive zinc supplementation. We have looked at multiple micronutrients as well as iron supplementation, and also evaluated the recent delivery platforms for iron and multiple micronutrients, which are these micronutrient powders. And we provide evidence of what is our opinion in terms of their impact on anemia and other outcomes that may or may not be of relevance to growth. We tried to put all of this together in an improved model for looking at impact on lives saved. And there are a few differences from what was done in 2008, which was a forerunner to the LifeSave tool, which is now in use for assessing impacts on child mortality. So one of the first differences is that we are now including also effects of wasting. So last time around, the model only included stunting, and we estimated impacts on severe acute malnutrition wasting separately. This time around, it's an integrated model. We are looking at not just all-cause mortality, we are looking at mortality by causes of death. So it's neonatal as well as under 5 mortality by cause, and we are including impacts on outcomes such as stunting and mortality, starting with pregnancy, birth risks that Bob has already pointed out. So the model takes into account various risk factors, the interventions across the life cycle, and their potential impact on stunting and life saved by cause. I want to briefly talk about the differences from the last model, because it's important, because people will read this and say, well, you said something else in 2008 and this is a different number. So the principle of the model remains the same. It's a cohort model that runs from birth to 5 years of age, and it has stunting and death as an outcome. Last time around, when Simon and I did this exercise with colleagues, the effects estimates on life saved or stunting outcomes were reported at a specific time point. So we principally reported impacts at 36 months or 26 months as an impact at that time point. Now that this cohort model is a little more mature, what is reported this time in this expanded exercise is the impact on stunting and on mortality across the entire under 5 period, which we believe is a better way of representing the data. And some of the differences from previous estimates relate to the way we present this. Overall, we believe that the effect sizes are broadly comparable. And unlike 2008, when we heroically went to a 99% targeted coverage, we have stayed within 90% targeted coverage in our projections. So these are the 34 countries, friends, which have close to around 90% of the global burden of malnutrition. And there is a brownie point for those of you who can point out the difference between this map and those that are in your booklet. So these are the countries, and you will see they are in sub-Saharan Africa and in South and Southeast Asia. We looked at the impacts and present the impacts in terms of effects by age and by causes of death. This particular graphic in the paper shows you 2 bars. One is the bars of what would be the cause-specific mortality if business continued as usual for various causes over time. And if these interventions were implemented at 90% coverage, what would be the impact in terms of reduction of mortality? And we provide a range of estimates, not just a point estimate, but we also provide a range in terms of what is the upper or the lower bound of those estimates for various outcomes that can be impacted by these interventions. In more specific terms, we indicate that the set of 10 nutrition-specific by 15% with a range from about 9 to 19% if implemented at 90% coverage across these 34 countries. That these interventions would reduce diarrhea-specific mortality by a third, pneumonia-specific mortality by about 30%, measles-specific mortality by about 40%, and would also reduce, from the limited evidence available, a chunk of neonatal deaths related to malformations that may occur from folic acid deficiency in the periconceptual period, and deaths that are attributable to small for gestational age, such as asphyxia. You will note that we have as yet little impact of these interventions on maternal mortality within the model, and Bob has already alluded to some of the limitations for that in our current effect size estimates. We provide an estimate, at least from the model, of these limited interventions leading to a reduction in stunting by a fifth. But as I've already pointed out, this is broadly comparable to what was projected at a time point of 36 months in the last series. This is across the entire under 5 age group for scaling up these interventions. And importantly, because this is an integrated model, we indicate that we can reduce wasting in children by about 61%, which is quite remarkable given the limited set of interventions that we have. We provide a slightly misleading figure. And this is the figure of what is the impact on mortality by these 10 interventions if implemented together. I say misleading because people reading this would say, oh, wow, it is only therapeutic feeding of severely malnourished children that leads to all of this impact, and everything else is very modest. We believe that some of these differences also relate to what we have and we were able to put in the model in terms of baseline coverage for current interventions. So for example, you will find that appropriate complementary feeding that we spent such a long time sifting out through the evidence does not save a huge number of lives in comparison to promotion of breastfeeding and therapeutic feeding. But that may relate to the way our current data sets provide coverage data for complementary feeding, which is generally only provided as age at initiation of complementary feeding in most data sets, and where you're able to put together data to give you an evidence of appropriate complementary feeding by dietary diversity or frequency, things begin to fall apart. So I think we can do much better than this during the course of the next decade as we start implementing this. But our current data set data limitations preclude doing more than what we provide in here. But nevertheless, you will see that from these 10 interventions, there is already a clear conceptual way of packaging these interventions together. And that's what I'm going to try and do, is to give you these 4 packages that we focus on in the paper as 4 packages for delivery which could make sense within health systems. 1, addressing maternal nutrition and health. 1 set of interventions focusing on infant and young child feeding, which is integrating breastfeeding and complementary feeding. Those that relate to micronutrient supplementation. And you will notice that these do not include iodine, which is considered separately because it does not impact mortality. It impacts lots of other useful outcomes, but it just does not fit within the LifeSafe tool model at the moment, and management of acute malnutrition. What do these 4 packages do? The first thing is they save quite a substantial number of lives. Management of severe malnutrition saves a lot, given the current way the model looks at this, but everything else also saves close to 100 to 200,000 children who are currently dying. The costs per life year saved are not huge. In relative terms, in comparison with many interventions on a cost effectiveness basis, these all turn out to be fairly reasonable investments in terms of the investment to save a life year. I want to say a word or two about delivery platforms, and in the interest of time, I'm only going to focus on the one delivery platform that we looked at specifically for reaching the poor and its impact on some of the inequities around undernutrition and associated complications. So the evidence base on community health workers and community programs that include some of the evidence around women's group has grown substantially over the last decade. These have been implemented both within research projects, large effectiveness trials, and also programs that countries have implemented. These health workers do a number of things. They deliver commodities, they work with communities for advocacy, they support women and communities around a range of interventions from reproductive health, maternal health, newborn health, and child health. The evidence on their impact on survival is now pretty strong, and most of it has been summarized in fairly robust Cochrane reviews or systematic reviews. One just published recently in the Lancet on women's growths. The impact on survival, as I said, across newborn deaths, stillbirths, perinatal mortality, quite robust and broadly consistent within projects with varying ranges of effectiveness. What has not been highlighted is what we point out in our paper is the impact on practices and behaviors that may also be relevant for nutrition. So breastfeeding rates more than double. Iron folate supplementation through these programs also substantially improve given the interaction of these health workers and workers with communities. Some of this evidence has also been summarized separately in the diarrhea and pneumonia series, and those of you interested can look that up. We were particularly interested in projecting and modeling if these health workers or programs were given a limited set of interventions to implement across the board, across various quintiles, what difference might that make? And many of these are specifically targeted to the poor. So the model looked at a modest range of things that these health workers do, and you will notice promotion, vitamin A supplementation programs, preventive zinc supplementation, and therapeutic zinc supplementation for diarrhea, and recognition and management of severe malnutrition. These are things that these health workers and community programs are already doing. They're doing much more complex things than this as well, including management of TB, DOTS, and hypertension recognition, and so on and so forth. This is a very limited repertoire of interventions. What difference might this make? So we modeled 3 countries for which we had data on distribution of child deaths across wealth quintiles. And these 3 countries are here: Pakistan, Bangladesh, and Ethiopia. And it doesn't take rocket science to see that the major emphasis and impact that we have is on reduction of mortality in the poorest quintiles. So overall, about 60% of the reduction is clustered amongst the poor because these programs have the potential of reaching those who are not being reached through traditional health services and health systems. So to summarize, our paper indicates that investments in nutrition-specific interventions and delivery strategies allow us a unique opportunity to reach those who are not being reached through programs at the moment. That their impact in terms of lives saved is substantial. 900,000 lives saved in children under 5 in the 34 high-burden countries, and reduction in number of stunted children by about 33 million. And I've shown you the numbers around that already. We believe that the targets that were set forward in the World Health Assembly for reduction in child undernutrition, stunting, are not pie in the sky. They are doable given the evidence base and the implementation opportunities that we have. How much will it cost altogether? So we provide a lot of detail and one summary table, which I put in front of you, as to what our current estimates are for achieving 90% coverage with these nutrition interventions. We're very grateful to Sue Horton and her team for having contributed to this robust exercise. And overall, the price tag is $9.6 billion for saving close to 1 million lives. And you will notice that some of this bulk is also for interventions that are very difficult to implement right now and may not necessarily be implemented as we speak. Things like calcium, things like complementary food provision, etc. But the investment is doable, and the investment is comparable with what people are already spending in health systems. So to finish, the key messages for this paper are that we can begin to implement some of our knowledge agenda in terms of what we know, the evidence-based interventions, starting off with addressing small for gestational age by investing in adolescent and maternal nutrition. We believe that these 10 nutrition-specific interventions have the potential to save lives, particularly if they are coupled with delivery strategies that I've spoken about. The cost is affordable for a world that spends close to around 100 times more than this on conflict as we speak. And there is an opportunity now to also link these evidence-based nutrition-specific interventions with the sensitive interventions that Marie Roel will talk about. Thank you.